to take care of the patients on ventilator. If they are comfortable and they know the APRV, definitely you can use it. Is a bi-level of ventilation APRV in which patient needs to breathe on themselves. You can't paralyze them. The patient are breathing at two area of PEEP, that is higher PEEP and a lower PEEP, and you set two set of time periods for the higher PEEP and lower PEEP. So it does have a pressure drop as well as when a pressure rise and for a significant amount of time. And patient usually you are titrating two PEEPs, and patient is breathing on those two PEEPs. Yep. So that's what
in SPM we are using APRV mode. In the severe ERDS, but if the patient has good outcome.
Abdullah, sorry to interrupt. I think we'll have to stop. We can take further questions online. Thank you very much. Excellent question answered and excellent talk. We'll just have a few minute breaks. Thank you.
So Dr. Riaz, I think finally we got a connection with you. So if you'll be in interest of time, if you can start your presentation, please. Thank you.
No, right. I'll share my screen. You can hear me okay?
We have introduced you earlier, so go ahead.
Fine.
Riaz is going to talk to us about renal replacement therapy. Thank you very much for joining.
Okay. So you can all see my slides, hopefully.
Yes, we can. Thank you.
Yes, great. Thanks. Okay. So, well, first of all, thanks you very much for inviting me to come and talk to you. So what I'm going to be talking to you about today is renal replacement therapy, and specifically with oncological patients, and why, when, and how. So I know that I've got quite a mixed crowd here, so I'm going to try to keep it relatively straightforward. So just to let you know that I work in Cambridge. It's a very nice place. You're very welcome to come visit us one day. And essentially we're in the east of England. Well, slightly hidden by this, but we're here. So as from a day-to-day basis, when you're a pediatric intensive care consultant, and particularly if you're on service, that it's important to know there's quite a significant interaction between the intensive care and the oncological service. It's one of the most common causes of admission to the PICU, and quite a lot of children will be admitted to the PICU who have a diagnosis of cancer during their treatment. About 38% of children will be admitted to the PICU at some point or another. And cancer really can affect, obviously, any body system. And so we have to think about, in many ways, how we're going to support that. But thankfully, in general, even if you combine elective and emergency admissions, the mortality actually is quite low. It's less than 9%. It's much higher if you take out the elective admissions. But in general, that's a product of us generally doing better intensive care. And predominantly, those patients come from will present with a respiratory basis or cause. About 45% of patients who come to the ICU are coming with some respiratory element. And the next comes sepsis and shock, about 30%, and neurological problems and tumor lysis make up pretty much the rest of it. And with those patients who have a pure oncological diagnosis pre-bone marrow transplant, as I said, the mortality is relatively low. But when you look at another group, which is the post-bone marrow transplant patients, that changes quite a lot. And we know from kind of historical data that children who are post-bone marrow transplant, if they have more than one organ failure, their mortality is very high. So when, as an oncologist, you have interaction with an intensive care doctor, should that occur? From an intensivist point of view, there are certain things that are useful to us and we may ask you. And so obviously the typological illness and its stage is important, and the degree of severe severity, its distribution, and if there's any metastatic spread. Also the availability of what the oncology service is like, and particularly if it's, you know, first interaction or something like that. And it's important to know what support we have. It's important to remember what policies and protocols there are for every particular diagnosis, in which protocol we're following, and also certain complications that we might be seeing and certain side effects of particular drugs, because many of the drugs that are used by the oncology service are not commonly used in the ICU, particularly chemotherapy. And also whether the patient is susceptible to any specific or diagnosis-related oncological emergencies and complications. So that's the kind of thing that we want to know. But really, kind of, you know, the most common things that we see in the most within the non-respiratory oncological diagnoses are hyperleukocytosis and tumor lysis, and we, from an intensive care point of view, we often kind of consider those to be in the same ballpark because the end result is the same. So from our local practice, we consider a white count above 100 as being hyperleukocytosis, but I know other centres use lower thresholds. And we know that hyperleukocytosis is a very common presentation of a lot of oncological diagnosis, and it's really a kind of a proxy marker for the tumor burden. And as many of you will know already, I mean, the things we have to deal with are hyperviscosity, thromboembolism, and there's normally, most big oncological units will have a protocol by which hyperleukocytosis is managed, a combination of hydration, drugs, and possibly leukapheresis. And as I said before, is that most oncological centers will have a good protocol for having to deal with that. But the natural extension of children who have either high tumor burden or high white count is the tumor lysis syndrome. So again, I know that the audience I'm speaking to knows this condition very well, and so I won't labor too much about the kind of the pathophysiology of it, but essentially tumor burden and cell lysis immediately result in rapid release of potassium, phosphorus, nucleic acids, which needs to metabolize and finally metabolize into uric acid, which has a renal excretion. And obviously the effects of high uric acid in the serum and deposition can have life-changing and potentially lethal effects. And as a subset of patients, obviously, again, from an intensivist point of view, the high count ALLs, the high count AMLs, the rapidly proliferating tumors and Burkitt's, things like that are sitters for developing tumor lysis. And those patients do very often come to the ICU, particularly during initiation of treatment. But as we know, depending on the presentation, there can often be pre-existing conditions. And if there's pre-existing renal dysfunction, that already puts you at higher risk. If you're already dehydrated, if you're already acidotic, then from an intensivist point of view, the alarm bells are ringing. So purely from a physiological point of view, and also kind of translating that into risk, the things that an intensivist is worried about primarily is hyperkalemia. And so again, going back to first principles, hyperkalemia is a life-threatening condition, primarily from cardiac arrhythmias, and it's really an emergency. But I mean, obviously, we will see children with urates, which start off relatively low, and as soon as you start therapy, that can be rapidly increasing, and that can overtake your renal threshold. Phosphate is another element of of tumor lysis that concerns us. And via the normal homeostatic mechanisms in the body, that also produces a hypocalcemia, which obviously has profound cardiovascular effect. So tumor lysis is a life-threatening condition. Often on the oncology ward, a combination of a pre-existing diagnosis with a high tumor burden, the expectation that chemotherapy is going to start. I'm hoping that for most of you, that tumor lysis will be high on your differential and high on your list of priorities and anxieties about this patient. And so in our center, those patients are very, we are spoken to quite early, our intervention and our involvement is relatively quick. And again, I mean, this is something that hopefully all of you know. So the cellular breakdown immediately causes and results in the breakdown of nucleic acids, which are broken down into urate. And the kidney has a threshold over which, if you overcome that threshold, and then you add the renal toxic effects of chemotherapy, antibiotics, antiviral and antifungal drugs, you add potentially thromboembolic events to that, which can involve obstruction of the renal vessels, both afferent, efferent, and also uric acid deposition in the collecting ducts and the tubules. This kind of all goes together to potentiate the effects on the kidney. So again, you guys will start treatment first of all with hydration, allopurinol and respiricase. We tend to use 1 dose of respiricase very early on in our center. But very quickly, when you add the combination of those things, there are a significant amount of patients will, for one of those 4 indices, will end up needing some kind of renal support. And I'll come on to that next. So it's important to, many of you will be familiar with the concept of hemofiltration and dialysis. And many of you won't. So it's just to go from first principle. So essentially there's an extracorporeal circuit, which means that blood leaves the body and it is taken through a series of mechanical devices, primarily a filter and a pump, and blood is filtered and through a semi-permeable membrane, and which allows differential removal of solutes. And that can be done in a whole variety of different ways, and I'll try to explain the ways that we can do that. But that's the basis of hemofiltration. So when you see a hemofilter, you might think this is a very complicated device. The concept of it is simple, and I'll hopefully keep it on simple concepts. So as I said, with the oncological patients, that combination of abnormalities that we see with tumor lysis are very amenable to treatment with hemofiltration, because primarily the metabolites that accumulate from tumors are small molecules, which the hemofilter excels at removing, and I'll explain why that is. But also the other offside, the other benefit of hemofiltration is that it allows you complete control over fluid balance, and because essentially, and I'll describe exactly why, it's very easy to control input and output, because you're essentially filtering the blood and you're able to control how much fluid is going in, how much is coming out, without the uncertainty of relying on urine output and other losses, which can be difficult to measure. Also, there is, you know, and again, I'll come on to that later on in my talk about whether it's removing other metabolites, whether it's removing other things which may be beneficial, which the jury may be out, but primarily fluid overload is the thing that we're also going to be hopefully managing. Now, there are a whole variety of patients that we look after that end up on hemofiltration, and they are children who have systemic inflammatory response and sepsis, not in our center, but in many other centers, post-organ transplant, fluid overload, post-cardiac surgery, post-trauma, severe burns. There's a whole variety of patients which may end up on the hemofilter, and also children, obviously, who primarily have renal failure, and that's anuric renal failure that they will have. So in our local center, to be honest, the majority of our patients who end up on the hemofilter are oncological. However, that's not necessarily the pattern over the whole of the UK. And different centers may have different, for example, the cardiac centers, the majority will be on hemofiltration, and that may well be via an ECMO circuit. Other centers, renal centers, the majority will be acute and chronic renal failure. But for us particularly, actually, the majority of our patients do have an oncological diagnosis. So what are the goals? So the goals really are to kind of mimic the functions of the kidney. Also kind of you're having a quantitative removal of a solute, which in this case is urate and phosphate and potassium. You're trying to maintain some homeostasis, and you're trying to avoid, obviously, the complications of those being high. And really what you're doing, if it's for a renal cause, you're trying to do a bridge to renal recovery. But in the oncological patient, what you're trying to do is that you're trying to give the hemofiltration in that initial phase when you're giving high dose chemotherapy and the urate level and the level of metabolites exceeds our renal threshold, in which you need additional support to be able to do that. And hopefully, as the tumor burden decreases and the intensity of the chemo decreases, most of the time our hemofiltration is only required the initial period. So what do you need to have to be able to initiate and maintain hemofiltration? So this picture here is a picture of the hemofilter itself, and we use a particular model which is made by a company called Baxter, which is called a Prismaflex. Other people may be familiar with other machines, but they have very much the same concept. It's an extracorporeal circuit, which means that the blood goes outside the body, and it needs large bore cannulas, venous cannulas, to be able to take the blood out, to be able to pump it through the hemofilter, for that blood to be under sufficient pressure to go through a filter, and then for fluid that's removed to be replaced. That's the basic concept. And you can see slightly in the picture there that there's a cannula there, blood's coming out, and there's a red and a blue. I mean, that's just there for simplicity. The blood is going through some plastic tubing, it's going through a pump, it's going through a filter. The thing on the side that you see there is a warmer, and as you can see there, that it needs large bore cannulas, and it requires a large amount of circulating blood that goes through the circuit. And you can see the pump there as well. And this is just a schematic of what happens. So primarily you need a large bore venous access, which we call a vas cath, which is similar to a central line, but has a much larger bore and is able to withstand negative pressure much better. The pump naturally generates negative pressure to remove the blood. It goes through some piping, it goes through a semi-permeable filter, and then through that filter, what happens is that the blood is separated by a product of diffusion and convection, and I'll tell you in the next slide what I mean by that. And you produce an effluent, which essentially is the serum being filtered out. We also use a dialysate, and a dialysate is there to increase the concentration across the membrane to facilitate more extraction. And then you end up with an effluent, which essentially is, we call it yellow, and then you replace that with whatever fluid you want. We have a whole variety of modalities that we use. The only important one really that we use is something called CVVH-DF, which is hemodiafiltration. And all you need to know about that is that we basically use all the mechanisms that are available to us in one go. So it's filters, and it produces, and it gives dialysis as well. And it uses both of those mechanisms. And oh, that's a duplicate slide. Okay, so this you can see there in the middle there's a membrane, and the blood goes through that membrane, and the amount of solutes that are filtered depends completely on that membrane. And the membrane, like any semipermeable membrane, has holes in it which allow certain things through. And the cutoff for it to allow things through are essentially the size of about an albumin molecule. So anything smaller, and as you can, I'm sure you remember back to physiology, and that obviously potassium, phosphate molecules are much smaller, and they're filtered out and end up in the effluent bag. And you can see that as a replacement bag, then we replace that effluent with a balanced buffered solution. And as I said, about the cutoff is about 50,000 Daltons, which is about the size of albumin. You have to remember that obviously, so big molecules are not going to be filtered out. And similarly, highly bound molecules, which are bound to large plasma proteins, are not going to be filtered out. And the physiological mechanisms are one, diffusion. So essentially you have what convection, which essentially means that across the membrane there's a hydrostatic gradient, and there's also and so fluid is going through that and it's being filtered, similar to making coffee, if you like. And you have another mechanism by which you have a concentration gradient across those things, and a combination of those things allow us the blood to pass through the filter and be separated out into those two component parts. And the small molecules, which are smaller, which can go through the holes of the filter, will end up in the effluent, and the ones that can't, and obviously red blood cells, white blood cells, platelets, are maintained within the circulation. And so that's the way that we were able to remove these small molecules from the circulation. And we use two effects. We use the filter, and you can see there the schematic shows there's a filter there, and blood is coming from the top. It's passing through the membrane, and a combination of primarily convection and adding the hydrostatic pressure is taking blood, separating the blood. What we also do is that we have a solution by which we're able to dialyze at the same time, and that has an additional effect that you are diffusing over a concentration gradient on top of that. So a double effect. And the effluent that we are creating is replaced by a buffered solution. And that buffered solution primarily doesn't have urate in it, thankfully, doesn't have other things, other toxins that you're trying to remove, but it is a physiological solution, and we can choose primarily between one that has potassium, one does not have potassium. And so if we are filtering for hyperkalemia, for example, we replace that fluid with fluid which does not contain potassium. But for the patient, it's one of the extremely important things about using a filter is that you're able to control so much. So essentially you are what you replace. In other words, we're able to control fluid balance, and we're able to control electrolytes primarily by addition of this replacement fluid into the circulation, which goes into the circuit, which when we go back to the schematic, it goes in either pre or post filter, doesn't really matter which, but essentially that's done to replace what we have. The membrane is this big cylinder in the middle, and there are different membranes depending on, sometimes you have to have specialist membranes to reduce certain things because there is an additional effect of absorption. In other words, there are some filters which can remove what you want to remove by way of absorption. In other words, it links into the membrane itself. As I said, the majority of patients will require a femoral vas cath for this, but I mean, you know, in older children, we often put in a internal jugular line, or occasionally have a subclavian line, but the majority are femoral and internal jugular. And I haven't said it very explicitly, but the implication, especially in younger children, is that how do you manage a filter with a child awake? And the answer to that is we very rarely do. So inevitably, in many situations, the patients are intubated and ventilated for placement of the line and to maintain the hemofiltration. The reason that we use such a wide bore line is because the machine is very sensitive to pressure, and the primary pump, although it has a pump in there, the primary pump is cardiac output, and the pump creates a negative pressure. And so it requires a really good, strong, big line to be able to maintain that negative pressure for us to be able to filter. I'll move quickly on to the complications. So obviously, you know, putting a big line to a small child is a difficult thing to do. Being able to maintain negative pressures through the line is very important. So a lot of the problems that we have are line related. So once you get a good line, it takes away a lot of the problems that you might have. Most of the time, and hopefully, I don't know how things work with you, but the orders for how the hemofiltration work is set by the intensivist. So we're actually pretty good at managing to make sure that we take off the right amount of volume of fluid, that we don't take out too much. I mean, obviously these patients monitor the intensive care, so that's done very readily. But I mean, as you can see from the filter, there's a large amount of blood volume in there. And so it can produce quite profound hypotension, and patients unfortunately, the ones which are going on the filter often are hemodynamically unstable. So you do have to make sure they're well filled. You may have to start them on inotropes. You may well have to get arrest drugs ready for them to go on. Otherwise, normally when the downsides of obviously having filtering blood is that you're losing a lot of electrolytes, and that can cause problems. But I mean, the whole ethos is that you replace those adequately, but with adequate monitoring, then they shouldn't cause you too many problems. Similarly, there's a lot of blood volume going in there. Sometimes we do something called a blood prime, which means that essentially blood goes through the machine and is given back to the patient to make sure they don't get anemic. But that's a relatively rare occurrence. Most of the time, we prime the circuit with replacement fluid. And obviously, I mean, it can cause, if you have a septic patient who's got renal dysfunction, who's got an oncology diagnosis, they're not exactly, well, they're often extremely sick patients. So it is important that they're very well monitored. But going on a filter can be, something that does provoke a cardiac arrest. And so we're very mindful of that. And so, as I said before, there are multiple interventions that happen for us to hopefully try to prevent those complications. And they're all on the ICU, so they're all well monitored. But so it's important that it's done in the right place. It's done with full intensive care monitoring. We use invasive arterial monitoring, almost invariably doing it, central line, VAS cath, intubation ventilation, fully intensive care. I'm going to just finish off talking a little bit about non-renal indications for hemofiltration. And obviously, the group, you are used to dealing with oncology patients who suffer from infections, from sepsis. And the vast majority of those patients, the first line therapy will be fluid resuscitation, antibiotics, etc. But I mean, in the patients, particularly who end up on the intensive care and patients who will be intubated and ventilated, hemofiltration is often a part of their management. But it's really only the sickest ones. And one of the difficult things, and one of the kind of debates, and it's not settled at all, is that whether hemofiltration in itself is of a benefit to these patients outside, and if you exclude the improvements that you see with fluid removal, adequate fluid balance, all renal support, all those things, and trying to separate out those effects has not really been possible from evidence. But I'll share with you a little bit of the theory around that. Now, we know that renal dysfunction and fluid overload are associated with high mortality in sepsis, but in the neutropenic oncological population. And the recommendations are that, I mean, if you look at surviving sepsis, it says that in the context of an acute renal injury, then there's a weak recommendation with a weak amount of evidence that hemofiltration is an adequate therapy to use. And in my day-to-day practice, when we see septic renal dysfunction, hemofiltration is used relatively frequently to support the kidneys, but primarily to deal with fluid overload. And I mean, surviving sepsis pretty much says the same thing, in that the benefit probably is with fluid removal, but to maintain good fluid balance, hemofiltration is there's a recommendation to use it if needed. But being able to extrapolate from that renal replacement in the oncological patient with sepsis is beneficial is a difficult thing to do. And it may just be that a child is so unwell that they require adequate fluid balance, and that's the benefit that they get. But we do know that children with an oncological diagnosis who end up on renal replacement have an extremely poor prognosis. And it's important to recognize that the poor prognosis you've seen is nothing really to do with the renal support. It's to do with the primary condition and the effects it has. And we know that if you take away, as I said early on in my talk about if you take away the elective admissions, children with multi-organ involvement with a cancer diagnosis have an extremely high mortality. But going back, and I'm going to slightly reference my colleagues talking about ARDS, in that there is a small amount of evidence that hemofiltration may benefit patients with ARDS, and in your subset of patients you may see that. And there are small studies which show that in the context of ARDS, you know, early high flow renal replacement can be a benefit. However, you know, the strong suspicion is this is completely related just to adequate fluid management, and whether there's anything else that's going on, and whether there's anything special, particularly about renal replacement therapy. I think the jury is very much out on that. And similarly, you know, of these patients who do have ARDS end up in the filter, again, their mortality is extremely high. So obviously these studies have limited value. I'm just going to take 1 more minute to talk about post-bone marrow transplant patients. And again, these patients, when they come to the ICU, have extremely high morbidity and mortality, and very challenging patients to look after. But within, not just in post-bone marrow transplant, but, you know, patients in general, you know, there's often a discussion about whether there's an additional effect of renal replacement therapy and whether it has a role in removing inflammatory mediators, whether it has the other roles. But I mean, I have to say there's no consensus about that. I mean, certainly there have been times when that's been felt to be a benefit in septic patients and neutropenic patients, and as many of you will know, in intensive care there are fashions, trends about these sort of things, but the jury's certainly out about what its value in being able to do that. Good, that's my 30 minutes. So I'm going to stop there if that's okay. And if there are any questions, then I'll be very happy to take any questions.
Thank you very much, Riaz, for excellent and detailed talk on renal replacement therapy. In the interest of time, I think we'll do the question and answer session in the end. So we're going to invite our next speaker, Dr. Khalab Abbas. He's the consultant intensivist in Al-Khan University Hospital. He's the associate professor and section head for pediatric critical care medicine. He's the associate chief medical officer, and he's a co-chair for the pediatric lung injury and sepsis integrated global health group. His interests are quality improvement in PICU and the training for the next generation of pediatric intensivists. Thank you, Dr. Khalab. He's going to talk to us about critical COVID-19 in pediatric oncology patients. Thank you.
Thank you so much for the kind introduction and invitation to talk about COVID in patients who have underlying cancer. And thank you so much to all of you for staying back at this hour of the evening. So I don't have any disclosure except that most of the data I'll be discussing and presenting has been extrapolated from the adult study. So there are very little pediatric data. However, I'll try to answer a few of the questions which I have put down for myself and for yourself. So do we know or think that SARS-CoV burden is different in children as compared to adult, and especially in general pediatric patient compared to patients who have underlying cancer? We'll try to answer that. Are these children with cancer are at risk of developing severe COVID and dying from severe COVID? Is it different? Is the disease itself different in children with underlying cancer than compared to other children? What are its clinical phenotypes? What are the options and evidence regarding the management? And then we'll summarize. So in general pediatric patients or in community or national studies, overall severe disease has been reported in up to 1 to 6% of children who had COVID positive test. And children with underlying comorbidities like cardiorespiratory illnesses or cancer or obesity, etc., have more severe disease, and it has been shown that they are at risk of dying from COVID if there is a comorbidity present. If we see specifically in children who are immunosuppressed or underlying cancer, they are at increased risk. And we know this from our historical knowledge when the influenza came and other viral infections in this specific subset of population. So we can safely say, based on the current evidence, that around 20% of children with cancer who get COVID go on to develop severe disease with a reported mortality of 1 to 10%. But this mortality, again, the major data comes from high-income countries. the data which we did a study, it was a multi-center study in which around 5% of the study population had underlying cancer, and their mortality in our study was around 17%. So, you know, it all depends on the setting and where do we come from. So, so I'll show you a little bit more that LMIC kids are more at risk of developing severe disease as well as mortality. So this is the worldwide national pediatric case fatality rate from nations who have had pediatric COVID-19 data. And if we see two specific regions which kind of reported a very high case fatality ratios are South America, Brazil and other countries, as well as in Africa. We had some data from Afghanistan, which also showed high case fatality rate in children overall, but we don't have any national data of children with COVID-19 from Pakistan. And if we see by country income, we see that LMIC children are at high risk of developing COVID, severe COVID, as well as their mortality rate is also around 4 to 5% compared to 1% in adult, and generally as in children. And if we see at the age, so younger children, traditionally infant age group, is more prone to develop severe disease as well as mortality. So their case fatality rate is around 4 to 6% as compared to older children. So if we see COVID-19 burden and the severity in children who had underlying comorbid condition, not specifically cancer, but overall any comorbid condition, we see that their severity has been more, and specifically they are at more risk of dying from COVID as compared to children who did not have any comorbid condition. And children with cancer are at increased risk of COVID-19, and the reasons are underlying immunosuppressed status, chemotherapy, as well as frequent visits and exposure to the healthcare facilities that put them at increased risk of acquiring infection from the healthcare providers or exposure from the hospitals. And the risk factor in this specific set of populations are severe immunosuppression, T cell deficiency or dysfunction, obesity, and then pre-existing cardiorespiratory condition. So this is a study which again came from South America and some North America, mixed high income and low and middle income countries, and that showed that children who had an underlying cancer had a mortality risk of almost, with the adjusted odd ratio of, they were more likely, 5 times more likely to die from cancer with underlying cancer and COVID disease as compared to other comorbidities. So yes, children with cancer are at increased risk of developing severe COVID, as well as at risk of dying from cancer. So what are the differences of COVID-19 in children with cancer? So we know, and all of you must have experienced that we found that they had a very long periods of viral shedding. And this one study basically studied the difference. This graph B shows the time from first positive test to last positive test, and the median time was around 15 days. So that is that the viral continues to replicate in children with underlying immunosuppression or cancer longer than in children who don't have any other comorbidity. And their replication clearance, that is the time from first positive to first negative, was around 22 days. So that also means that they continue to shed viral for prolonged periods. And this has a impact on the decision to hold or restart chemo, or how do we start chemo in these patients. Other than that, these patients have underlying, especially children who have hematological cancers, have hematological disturbances. So sometimes it's difficult to differentiate that the underlying D-dimers are because of the disease, or it is because of the COVID-19. And then it is also tough to decide sometimes, especially initially in the pandemic. In the earlier days, it was tough whether we manage these patients online of febrile neutropenia, or this is COVID, or do we need to change the protocol? But now we are very clear how to manage. So COVID has affected children in two ways. One is the acute phase, in which children primarily present with either a hyperinflammatory state in which they have fever, body aches, and other constitutional symptoms, and they have high or raised laboratory parameters of inflammation. So that is called kind of a hyperinflammatory state. Then the other phenotype in acute COVID is respiratory illness, like development of upper respiratory or lower respiratory tract infection, and that can go on to the ARDS. And third is, if this continues to happen, then it can progress to severe sepsis and a multi-organ dysfunction syndrome like. The other big phenotype in these children is a delayed phenomena that is immune mediated, and this is called multi-system inflammatory syndrome, or PIMS as the UK people say it. So again, it has different subsets of phenotypes. One again is hyperinflammatory, where there are increased markers of inflammation. Then some children were found to have coronary involvement similar to seen in Kawasaki disease. Some presented with rash and toxic shock-like syndrome, and some presented with myocarditis. So if we see the different differentiating features between all of these phenotypes in MISC, we see that MISC traditionally has been found in adolescent or in early adolescent years. GI symptoms were one of the major presenting symptoms. There was predominance of myocardial dysfunction. Platelets were found to be low or normal in these children, and they had significantly elevated levels of D dimers as well as elevated troponins and pro-BNP as compared to the traditional toxic shock syndrome or Kawasaki disease. And if we compare this MISC with myocarditis, so we saw again the same laboratory findings, that they had this MISC, Kawasaki, and myocarditis had low leukocyte count, more neutrophilia or relative lymphopenia, and then they had low platelets, as well as they had high CRP value as compared to the historic Kawasaki and myocarditis. So then if we see the severity of COVID-19, so there are certain specific definition to define that what is the severity of COVID. This is important to know because our therapy titration then depends on the severity of COVID-19. So it can be asymptomatic, it can have simple URTI like cough, coryza, and other some breathing difficulty with no oxygen requirement. And if this is there is oxygen requirement, or if there is low respiratory tract infection, then this is labeled as moderate. And if the children present with respiratory distress, or there is a need for ICU or invasive ventilation, then this is described as severe. And if this goes on to develop ARDS or need for invasive mechanical ventilation, then this is called critical COVID-19. So immune deficiency severity is also important to understand. I won't go into detail, and this because our decision about whether giving some specific therapy to these children or escalating or de-escalating therapy depends on three things. One is hypoxia, the other is this severity of the COVID-19 disease, and the third is the severity of immune deficiency. So this is data from the Global Cancer Registry, and that shows that around 20% of COVID-19 children, positive children who had underlying cancer, go on to develop severe or critical COVID, and the major diseases were hematological malignancies. So if we see the definition of multi-system inflammatory syndrome, so it basically says that if a child has a fever of more than 3 days with clinical signs of rash, conjunctivitis, mucocutaneous involvement, with shock or cardiac dysfunction or evidence of coagulopathy and GI symptoms, anything 2 out of these 4, plus raised inflammation markers and no other obvious diagnosis, then you label these children as having MISC. Obviously, we need to have some evidence of COVID exposure in the form of positive serology or PCR. So this is the WHO definition, and the other definition is from the CDC US. So again, MISC severity is important to understand because our therapy depend on the severity. Again, if a child has only fever with no shock and minimal respiratory support or evidence of organ injury, then this is mild. If they require supplemental oxygen support or they are in shock or have evidence of myocardial dysfunction, then this is moderate to severe. And if they are in the ICU or they have significant organ dysfunction or need for invasive mechanical ventilation, then this is critical MISC. So coming on to the management, so we need to assess the severity or the extent of disease in these patients. So we go on to see the CBC, inflammatory markers. We check the SARS-CoV-2 PCR or antigen or antibodies depending on the history. And then we need to have serial complete blood count as well as CRP and procalcitonin to understand the response to therapy and whether to escalate or de-escalate therapy. And then organ assessment is important in all these children. So we need to screen kidney, liver, brain, and obviously lung. And then we can also test other tests like D-dimers, lactate dehydrogenase, echocardiography, and chest X-ray based on our initial history and examination. So coming on to the management, so organ supportive care is the principle of management for these children once they are in the ICU or in the hospital. So respiratory support, as my colleagues have already discussed, the ARDS and NIV are invasive mechanical ventilation. So I'll just skip that. In hemodynamic, we need to provide them with good fluid therapy and vasopressor support depending on the need to keep the organ perfusion intact. And we can use milrinone or epinephrine depending on the physiology at that particular time. Then fluid and nutrition are important part of the therapy along with the proton pump inhibitor when we are using steroids. Renal replacement therapy has already been discussed. So if we come on to the specific, then we have the options of steroids, antivirals, specifically remdesivir. Then we have immunomodulators like intravenous immunoglobulin or tocilizumab and others, and then anticoagulation. So consideration, as I already mentioned, are whether the child is hypoxic or not, what is the severity of COVID disease, and what is the severity of immune deficiency or immune suppression, and at what stage of that particular cancer is the patient on. Is it the induction therapy? Is it the consolidation? Is it the maintenance therapy, etc.? So coming on to the steroid, dexamethasone, as per the recovery trial, is the drug to go in these children that can be given orally or IV, 0.15 mg per kilo per dose up to 10 days, depending on the symptoms. It can also be considered in COVID-19 in the absence of hypoxia, but if there is ARDS, shock or adrenal crisis, and the alternatives are methylprednisolone or hydrocortisone. So this study has just been published in JAMA in 2022, and that it kind of, so if we see the evidence of steroid in COVID-19, so this study basically says that early start of steroid in children with COVID-19 who are hypoxic, so there was no mortality benefit or effect on the length of hospital stay in these children. But still the WHO as well as other all other societies recommend using steroid in children who are hypoxic. So then next question is, do we go with the DEXA always, or do we have other options? So there are a couple of studies which have been done in adult in COVID-19 hypoxic children and ARDS, and they showed that methylprednisolone has a mortality benefit in adult patient with COVID-19. It led to less need for stay in the hospital, as well as less need for oxygen therapy, and as well as the severity of the COVID-19 was also better in the methylprednisolone group compared to dexamethasone or hydrocortisone in the couple of these randomized control trials. Next is the remdesivir. So remdesivir is a RNA-dependent RNA polymerase inhibitor. This is the only approved antiviral in adults as well as in pediatrics. So WHO recommends to use this only in certain circumstances and not as a routine in all children with COVID-19. So children above 3.5 kilos and less than 40 kilos can be started with a dose of 5 mg per kilo, loading followed by 2.5 milligram once daily for a total of 5 to 10 days. But discussion with the ICU physician, oncologist, as well as the infectious disease persons is really important. So these graphs just show the time to liberation from the invasive or non-invasive mechanical ventilation was better with the use of remdesivir as compared to children and adults who are treated without remdesivir. So precautions are acute liver injury or acute kidney injury, and in patients who have multi-organ dysfunction, then we have to be really cautious about using remdesivir. Then IVIG has not been shown to be of any proven benefit in children with acute COVID-19. It might be helpful in certain population subset like who are at risk and just dying. So some people suggest that you can just throw in whatever you have, and in patients who have MODS with high inflammatory markers. Tocilizumab is a humanized monoclonal antibody that interferes with IL-6, which is IL-6 is the main potent pro-inflammatory cytokine receptor binding, and it is implicated in the CRS and the MODS after COVID-19. But the important consideration before starting tocilizumab is screening the patient for any potential infection, including tuberculosis in our setup. And the adverse effects are infection, cytopenias, and hepatotoxicity. So we again have to think that about before starting that and screen the organs. That is, if the patient has cytopenia or liver injury or evidence of infection, then this is not a good choice. And once we start tocilizumab, then CRP is probably not a good marker for disease progression. Then another proven drug or a drug which has been given emergency use approval is baricitinib. It is an orally administered JAK1 and JAK2 inhibitor, which reversibly inhibits the intracellular signaling of multiple cytokines. It also has been shown to have some antiviral properties against SARS-CoV by inhibiting the ACE receptors. It is previously approved for atopic dermatitis, and FDA approved it for use in children with COVID-19 above 2 years of age who are receiving invasive or non-invasive ventilation or on an ECMO. And the duration of therapy depends on the disease severity and progression. It can be used for 14 days or until the patient is discharged from the hospital. But again, if there is renal or liver impairment, or if there is lymphopenia or neutropenia, then we have to be really cautious. And again, in the presence of tuberculosis, this has to be reconsidered. Other options which are being studied by different studies but not proven are rotenavir boosted Paxlovid for use above children in above 12 years of age. And then few other antiviral and monoclonal antibodies are also in the pipeline for use in COVID-19 in the future. So coming on to the thromboembolism. So thromboembolism should be considered in children, traditionally in children above 12 years with at least one risk factors, or when the D dimers are above 5 times normal limit. And if the age is less than 12, then if the risk factors are 2 or more than 2, or the D dimers, or if there is one risk factors and the D dimers are more than 5 times. Duration has to be individualized based on the risk factor, hospitalization, the duration, and the COVID symptoms. And the list of risk factors is huge, but mainly if there is a catheter present, like central venous catheter or a PICC line or West cath, etc. If the child is on mechanical ventilation, if there is a anticipated length of hospital stay of more than 3, if there is complete immobility with a Braden Q mobility score of 1 or less, if there is obesity, if there is an active malignancy not in remission, nephrotic syndrome, and other hypercoagulable states, if there is recent administration of asparaginase, congenital or acquired cardiac diseases, a previous history of venous thromboembolism in the child or in the family, if there are conditions of non-thrombophilia like protein C or S deficiency, or if the children is receiving an estrogen-containing oral contraceptive pill or post-splenectomy. So all these are risk factors for children to develop venous thromboembolism, and in these children, thromboembolic preventive therapies should be considered in the presence of COVID-19 disease. So post-exposure prophylaxis, there is no data in children, and it is not recommended because there are some studies and some people have used post-exposure antiviral like remdesivir and other antivirals, but the data is not supported, and this is not recommended. So in summary, if a child has critical COVID-19, so then irrespective of the underlying immune deficiency, antiviral therapy should be started, again, keeping in consideration the underlying organ dysfunction, especially the liver infection and renal injury. IVIG can be considered if the IgG levels are less than 400 milligram per deciliter. Steroids or basitranib or tocilizumab can be considered on a case-to-case basis based on the multidisciplinary team consideration. Coming on to the MISC, so again, supportive management is basically the respiratory support. The hemodynamic management in these patients is of utmost importance because cardiovascular dysfunction is one of the main features of MISC. And there are two things which are important in these children. One is the fluid resuscitation when they present to the ED or in the ICU on arrival, and then followed by the use of early vasopressors. And again, our armamentarium is epinephrine, milrinone, norepinephrine, and other vasopressors drug. Then fluid and nutrition along with proton pump inhibitor if we are using steroid, and renal replacement therapy as per need. So again, the options for these children with MISC are immunomodulators, including steroids and IVIG, aspirin and anticoagulants as per the standard risks. And follow-up in these patients is important from cardiac point of view. So consideration in these patients is overlapping diagnosis, because you see, if we see the MISC, we can have a lot of children with underlying cancers. And we also saw that dengue patients presenting with raised inflammatory markers and all those thrombocytopenias and had overlapping features with MISC. So then it really become important to individualize the diagnosis as well as the management. So cardiovascular support, as I said, is judicious use of balanced crystalloids, boluses of 5 to 10 ml per kilo normal saline, which should be slow, with keeping in mind the red flags of anemia, because anemia is one of the common presentation from community in children with cancers. Severe malnutrition, again, cancer children are at increased risk of severe malnutrition if they have pneumonia or myocardial dysfunction. Then our fluid therapy has to be adjusted. And hypovolemia in these patients is because of capillary leak, decreased intake, and vasodilation as underlying physiology. And if we have decided to give bolus to these children, then it is important to assess for the signs of improvement or the deterioration. If there is reversal of tachycardia, if the capillary refill time, the pulses, perfusion is improving, the shock index is decreasing, then we are on the right track. Otherwise, we have to switch our gear, restrict the fluid, start vasopressor, and sometime maybe we have to start respiratory support along with diuretics. And early vasoactive support, depending on the physiology and the blood pressure, even if the blood pressures are normal, but the capillary refill time is delayed, we have to start these patients on vasopressors, and the choice can be epinephrine or milrinone or dopamine depending on the setting. So therapeutic option, if the disease is mild, then it is recommended to start IVIG 2 gram per kilo over 12 to 24 hours, along with 1 to 2 milligram of methylpred per kilo per day. If the disease is moderate to severe, then IVIG over 12 to 24 hours, followed along with steroids, that is pulse or high dose 10 to 30 mg per kilo per day for 3 days, and then followed by a slow methylpred taper over 2 to 3 weeks as the disease defervises. And in refractory cases where the fever is not settling or the inflammatory markers are persistently elevated, then people have studied and considered the second dose of IVIG or using anakinra or tocilizumab in those selected cases. So if we see the evidence behind steroids or IVIG or combination, so there are conflicting reports. So 3 RCTs have been done so far. One RCT was done from US by the Overcoming COVID-19 group, and they showed that steroids along with IVIG has a definitive survival and disease, stopping the disease progression benefit. While the BATS group from the UK said that the evidence is kind of plus minus, and with steroids plus IVIG or IVIG alone. And a meta-analysis also proved that patients who receive IVIG plus steroid have better left ventricular dysfunction and less need for inotrope as compared to patient who only got IVIG. So the bottom line is that patients who come to us in our setting with MISC, and the severity is severe or critical, start with steroid high dose, and if there is availability of IVIG, then go ahead and do them. Then thromboembolism and anticoagulation, aspirin low dose 3 to 5 milligram up to 75 mg daily till the platelets are normalized and the coronaries have been found to be normal at a 4 to 6 weeks follow-up. Precautions has to be taken if there is active bleeding or if there is risk of bleeding or platelets are less than 80,000. And if we have to use heparin, then the indications are coronary aneurysm, if there are multiple or complex aneurysm, or if the LV functions are less than 35 with the presence of thrombus, then heparin has to be low molecular weight or warfarin has to be started. And then this is bridged to aspirin and followed up. And so in summary, risk stratification and individualized therapy is important, and the therapy is based on decided on the presence or absence of hypoxia, immune suppression, as well as the disease type and severity. Decision has to be made regarding withholding or continuing the therapy, chemotherapy, and the available drugs are steroids, IVIG, remdesivir, and tocilizumab. And in MISC, I would suggest start with steroids. If you have IVIG, then go ahead and give steroid and IVIG both. Consider anticoagulation based on the risk factors, and use the principle of multidisciplinary care as well as the organ supportive care in these patients. Thank you so much.
Thank you very much, Dr. Kalab. So questions we'll have at the end of the session. So in interest of time, this will be our last speaker. So we will have Dr. Shakila Khan. So Dr. Shakila joins us online, and she joins us from the Division of Pediatric Hematology, Oncology, and Transplant at the Mayo Clinic in Rochester, Minnesota, in the US, where she is a professor of pediatrics. Previously, she was the director of Pediatric Hematology Fellowship Program and the Pediatric BMT director. Her research interests are stem cell transplant for non-malignant disorders, graft versus host disease, and optimization of cellular therapy. And her topic is going to be interesting for us intensivists, and she's going to be talking about physician burnout. So over to you.
Hello, Assalamu alaikum. I hope you can hear me and see my slides.
Yes, we can hear you. We can't see your slides.
You can't see my slides because I'm sharing. Okay, I'm sharing through Zoom, which I do all the time. So. Share screen. Can you see my screen? Because I'm doing share screen.
We can see you, but we can't see the screen yet.
Okay, can you see it now?
Yes, we can see it now.
Okay, so it looks like I can't do the show because I was trying to do that with you folks, which is interesting. All right. Okay, can you see it properly now?
Yes, we can see it now.
Great. So thank you, Dr. Sadaf and the organizing committee for inviting me. I wish I could be there, but this topic is, very dear to my heart, and I have a lot of interest in this, as well as, my background in palliative care. So I hope that, and my hat's off to you guys. We are very spoiled at Mayo. We have everything, very easily available. And so when my colleagues get frustrated and upset about things, I always tell them that you should visit developing countries, because I do that. And it's, it's very hard what you guys do. So hats off to you. So what is burnout? Burnout is a syndrome of depersonalization, emotional exhaustion, cynicism, and low personal accomplishment, leading to decreased effectiveness at work. And of course, we all became doctors because we thought we'll help humanity. So there is loss of idealism and commitment, loss of meaningfulness in your work, feelings of guilt and unworthiness, and loss of direction and purpose. And of course, physician burnout influences the care we give to our patients. Safety is at risk. And then physician turnover. People go, leave. And also patient satisfaction is affected. So, and what is the cost? Medical errors, professionalism, patients, as we talked about, patient satisfaction, reduce hours, suicidal ideation. Hopefully we don't have that. One of my colleagues who's very interested in it one day told me, do you realize that females have a higher rate of suicide than males? And I was like, really? I didn't know that. So anyway, I was looking for some articles because I think coronavirus has put added stress on everybody. And we actually had a lot of people leave because it was really hard, especially the healthcare workers in the US also were very stressed. So I thought, let me look at some studies from Pakistan, and I found this published in 2021, which actually addressed the impact of mental health issues and burnout. And it was a cross-sectional survey. I thought it was a small study, but I thought it was very important. It is a single center experience, and tertiary care hospital in Karachi, which is the Aga Khan, that was the paper from. And they use the WVS, which is the Warwick Edinburgh Mental Wellbeing Assessment to assess mental well-being, and Maslach burnout inventory, which I'll talk a little bit about to assess burnout. 87 physicians participated in the survey. Mean age, as you can see, was younger group. And they noticed that emotional exhaustion was observed in 54%, depersonalization in 77%, and low personal accomplishment in 31%. That was pretty high. And emotional exhaustion and depersonalization was greater in residents, especially those working in COVID units. I thought this was interesting. Higher in unmarried versus married, probably because of the support. And they found that there was correlation between mental well-being and burnout scores. So they did have suggestions to address these issues with training, workshops, counseling, and psychotherapy. I'll quickly go over the Maslach burnout inventory because this was developed in the 80s, but it still is being used all over. And more than 30 years of validation. And it has 3 subscales: depersonalization, emotional exhaustion, and low personal accomplishment. And then normal samples for other physicians too. So I won't go over all of this just because I've done this previously also, and you may remember it, that, there are questions like, I feel emotionally drained from my work, feel used up at the end of the day, feel tired when I get up in the morning and have to face another day at work, means that you really don't enjoy what you're doing. And especially for our oncologist, I think this is number 11 is important, that I worry that this job is hardening me emotionally. So frustration at job, working too hard, too much stress. So anyway, so Tate Schoenfeld, actually, he was at Mayo Clinic and he started this, and now he's gone to Stanford and is managing and heading the department there for this, is that he did a cross-sectional survey. He was an oncologist here. And we have the Society of Clinical Oncology, and he actually found out, used the Maslach burnout inventory, that only 33% were satisfied with work-life balance, and 26% plan to reduce clinical hours in the next year or so, and 34% plan to leave the current position. And women had a higher rate, is what he of work, concern about work-life balance. And again, with work-life balance and burnout, strongest predictors were intent to reduce clinical hours and leave current position. So hopefully you can see this slide, but this just shows pediatrics, and pediatric subspecialties are way down compared to the adults. And I think the reason is that we, as pediatricians, talk a lot more to our patients, and so I think we don't get sued even as much as the adult folks. So I think because that's the way we are trained. And I have to tell you, pediatrics is a top field in Pakistan. When I came to the US, I realized it was at the bottom of the ladder. But people go into pediatrics knowing that. So I've always gotten feedback that pediatricians are always the nicest folks, because they go because they have a passion for doing what they do. So about a little bit about pediatric oncologists. This was done as a survey. Again, this was published in 2011. I found a more recent study too, which is similar. And it says that it was 40% response to the survey. 30% of those had higher burnout, while 72% had moderate levels. And women, again, had higher burnout compared to men. And physicians, this was interesting. So this was a little reassuring, because I'm really old, planning to retire soon. But the physicians practicing less than 10 years had higher rates of burnout versus the older ones. And physicians who reported satisfaction with lives outside work were less likely to have burnout. And if there wasn't availability of a forum of debriefing and services for physicians affected by burnout, their burnout rate was less. An interesting finding was that 36% reported that the institution had debriefing, and 40% said that they had services available. This was a study from Canada, which shows that, again, a pediatric oncologist, and sadness, crying, because we deal with grief when we lose our patients. It's not easy. And so, that can also affect how we work and can cause burnout. So this was another study which in the US, again, something similar, female sex and burnout score, distress about a clinical situation in teaching were associated with higher scores. And they highlighted the importance of strong social connections at work and at home to decrease burnout and enhance quality of life. So a little bit about Mayo, because they did a survey and said that nationally the burnout rate in US is 48%. And there was an annual survey done in 2017 where our former CEO was very surprised to see that 32% had a burnout, and it's been sort of staying there. They did not separate out pediatrics. So there's much fewer reports for pediatrics, but Dr. Schenefeld and our CEO at that time, who was very surprised, they actually had this organizational strategies to promote engagement and physician well-being. And they said the first thing is, I hope your administrators are listening, or maybe they can see this talk. Acknowledge the problem, harness the power of leadership, develop and implement targeted interventions, cultivate community at work, use rewards and incentives wisely, align values and strengthen culture, promote flexibility and work-life integration, provide resources to promote resilience and self-care, and facilitate and fund organizational science. So we actually have a well-being Mayo website for employees, which is very important. And they have been working on it continuously. And there is a newsletter which comes out to everybody. And they have workshops. And you see the workshops and you can attend them online or do it. And I received this survey recently, so I thought I'll copy it and put it in. Every 3 months, they ask us to do a physician well-being index assessment online to see how we are doing. And this shows the 12 habits of, people when we are walking in our stairwell or elevators, they have one thing every time for a week or so, trying to sort of say, like energize your life, discover your why, prioritize your task, play to your strengths, etc. So a little about this program, which was developed by Dr. Amit Sood, who was at Mayo. He's actually not at Mayo anymore, but he has a website, and I will give you this website. He had this course for stress management and resilience in training, and I took part in it. This was about 7 years ago. And he did research in mind and body connection, and had developed this SMART program. And it is adapted from attention and interpretation therapy, which is called AIT, and combines neuroscience, evolutionary biology, psychology, and philosophy. And it teaches skills to train attention and interpretation. And he says that our brains are wired in a way for stress, and from the caveman time, survival and those things. So he calls it right wiring the brain. And several published studies have shown this to be effective in improving stress, resilience, anxiety, quality of life, and mindfulness. And it's actually very simple. You'll be very surprised at it. It has shown efficacy for improving happiness, health behaviors, and burnout in healthcare employees. And all new physicians, nurses, and medical students at all 3 Mayo sites were required to do a course in resiliency as part of their training. So I was very impressed because of the simplicity of the program. So, and the SMART postulates that brain networks are organized into 2 modes in which the brain alternates. Focus mode is engaged when a person is doing something enjoyable and immersive. And this is what we have to improve on. Default mode is when the mind wanders and the focus is distracted and it perpetuates a stress response. I'm trying to teach my daughters this, and so it's not that easy. And at the end of a stressful day, a physician spends time thinking about work instead of spending relaxing time with family, and this can be negative and unproductive. And I have to tell you, my daughters sometimes complain, Mom, you are not listening, because this was very true. I was thinking about what had happened if I had a difficult patient, something like that. So what does SMART do? It helps break this pattern and replaces stressful with thinking with productive and positive thoughts. So to overcome the brain's default tendency, SMART promotes developing intentional attention, which is deeper, better focused and sustained. Better focused and sustained. Use brief spurts of 1 to 3 minutes instead of long practice. Because yes, there are meditations, yoga, everything. Buddy says that, but the beauty of this is that he says you don't have to do it for very long. These short meditations contain an element of positive emotion that increases the effectiveness. So focusing intentional attention is what he talks about. Joyful attention. So morning gratitude. I actually thought this was so good. We believe in religion, and this is more spirituality. But if we got up in the morning and thanked Allah for what we have and start the day in a positive way, it does make a difference. And this is one simple practice I do every day, that you have to thank God for your blessings and look at the positive things in your life and not the negative. And then give at least 2 minutes of your undivided attention to one person who deserves it, is I'm not getting any. It could be your children, it could be spouse, whoever. And then notice one new thing in the world around you every day. Look around, find something. Maybe look at if you're going, just your surroundings. We are so involved with our phones and everything. We don't pay attention to our surroundings, how beautiful it is. And I have to tell you, the sunrise and sunsets in Minnesota are beautiful. And once I noticed that now, I show it to other people too. There's something called kind attention. Send silent good wishes to people you meet or see during the day. So it is like if you're in the elevator, you can just silently wish all the people in the elevator well. And total time invested in attention exercise should be 5 to 10 minutes a day, not more. And he gave an example. Look at this flower. He said, we look at flowers, we look at things, but we don't look into the details. And that's called attention, is that you focus your attention on one particular thing. And that actually helps. So what are the core principles of this SMART program? Gratitude, compassion, acceptance, meaning, and forgiveness. And I'll just briefly go. You can have a daily theme. Monday be for gratitude, Tuesday for compassion, Wednesday for acceptance, Thursday for meaning, Friday for forgiveness. So compassion is that, be kind to somebody. An example is, I sometimes get frustrated driving, somebody cuts you off. He says, think of it, maybe they're having maybe they're having a bad day. Instead of cursing them, just be a little more sympathetic. Acceptance is that, you accept things and find, I should say this, that, if something bad happens, just look at it in a different way and accept it. So if somebody's not kind to you, look at it in a different way. Meaning for things, meaning for life, meaning for what you do. And forgiveness is to forgive, as I told you about compassion, and expression other than love is a call for help. Meaning is with relationships, work, and spirituality. And, your family, siblings, parents, colleagues, neighbors, pets, everybody is important. Forgiveness is not justifying, condoning, excusing, and denying. I found this, that forgiveness, if you somebody does something bad to you, and that happens, I mean, it happens to everybody, even at work or in family, you have to think about that, and it is a voluntary choice, and it allows you to live by your principles. So I think there's a big thing on about forgiveness. So just to go over 3-minute rule about morning gratitude and notice things, kind attention, good wishes, and intentional thinking, align your daily thoughts with the higher principles, and you're off for Saturday and Sunday, celebration and reflection. This is his website, if anybody is interested. So this was about, the SMART program, a little bit about time management, because I think that causes burnout too. And it affects, especially with our phones, email overload, all those things. It does affect how we function and adds stress to the day. So that's very true, right? Time management is a great concept, but who has time for it? So what are the time stealers? Lack of direction, inability to say no. Sometimes you just can't say no and you take on too much. There are a lot of time wasters, especially your phones and emails and all that. Procrastination, distractions, negative attitude, interruptions while you're working, poor systems and procedures, failure to delegate, correcting others' mistakes. Open door policy. Shut your door if you're doing something important. It is fine. People can, have to realize that they can't barge in all the time. Attention to detail, excessive emails, and my favorite, social media. I don't go on Facebook or any of these things because I think it does suck up your time. So basics of time management is set realistic goals, get organized, delegate, relax and recharge, and stop feeling guilty. Set lifetime goals. Create a to-do list for the week. I am a list person. I always feel very happy when I scratch it off what I have done. And compare the two to determine if there's anything on your to-do list which could ultimately relate to your lifetime goals, and important to work towards your lifetime goals in addition to doing the immediate task. And when I mean lifetime goals, what do you want to achieve in your profession? What do you want to achieve in your family life? What is your goal for that? Organization, organizing stuff and organizing time, both are necessary for success in accomplishing your goals. When you make your list, make time for planning and prioritizing, organizing and filing your stuff. Throw out things you don't need and find an easy system, as it is an ongoing process. I delete most of my, I think about 60% of my email is irrelevant and I delete it. So control your emails, 4 Ds, do now, dump, delegate, and delay. Most can be read and dealt with immediately. Only a minority of items should be delayed. Make a file for those. And set aside time in the day to deal with emails. Maybe do it in the morning and then in the afternoon. Don't check it every few minutes. That's the key, because that does take up your time. So they do say maybe morning or in the afternoon before you leave, check your emails. Emails interrupt thoughts, sap productivity, and undermine your ability to concentrate at work. Better to define an email-free zone in which to work. Do not log on to Outlook, and do not permit the new message signal to flash. That is something I've turned off. Now we have, in all my emails, I don't like that popping up. And don't send replies unnecessarily and insist that you and your colleagues will never hit reply to all. I hate reply to all because it's most of the time, then if it's a whole group of 25, you're getting 25 emails. And it is not time efficient to respond to individual emails the minute they arrive, and keep your email software off except for twice a day. Check at times of your own choosing. Other strategies are delegate whenever reasonable and possible, balance work and life. have time for relaxation, vacation, and time with family. Results of having a downtime is a brain that works better during both professional and personal time. Ditch guilt. We are hardwired to feel guilty about all sorts of ridiculous things, and that leads to more stress and anxiety. Thank you. If there are any questions, happy to answer.
Thank you very much, Dr. Shakila, for a very interesting talk. In the interest of time, do we have time for question and answer session? I think there was none in the chat box. Yes, please go ahead.
Oh, okay. This question for Shakila. I really enjoyed your talk, and I'm at that stage of life when this is extremely important. But what I wanted to ask was, you know, that Pakistani study you talked about, they were at 30 years of age and were talking about burnout or really
Yes.
feeling stressed. So do you think they looked at the underlying stressors? Because is it low pay and overwork and not getting enough holidays and, you know, things that really, really matter? Because both my children are doing their F1s these days, and they get 27 days off a week. Every few days they come home because they've got days off, they've done weekends or things. So, I mean, I think we need to be looking after our junior doctors as well. And also, do they have good mentors like us who make sure that they go home on time? Ask them if they've got things going on at home which is stressing them, because often I think the workplace doesn't give them enough allowance to. I'm talking about juniors. Obviously, your talk to people like us is very,
Yes.
very good.
So,
But for juniors, maybe we should be thinking of other things too.
yes, and I think that's what is very important to explain that, and this applies to everybody, whether you are young or old. But somehow in all the studies, I think that experience and maturity helps reducing burnout. That actually was shown even in the US. And the younger physicians get more stressed, I think, because they don't have the coping mechanisms which the older physicians develop. I think that is a very important thing. So you are absolutely right. You should be helping them. And that's why, so these websites I was showing you, and there has to be a group sessions what we call, like if a patient dies, it's much better for the whole group who took care of that patient to come together and just went. And that actually helps a lot, especially in our pediatric oncology. We lose patients and it is very hard. And I do palliative and hospice care. And I have to tell you that that's not easy, but just sitting down with everybody and talking about it gives you closure. And so I think you are absolutely right. You should be, and mentoring is absolutely very, very important.
No, I'm just saying because a lot, I mean, I don't know how many senior people are around, but we all probably should be consciously doing it. I mean, looking
Absolutely.
after ourselves and our colleagues, both important. Yeah.
Absolutely.
Thank you, Dr. Shakila, for this very interesting talk. I just wanted to put a question to you regarding use of social media. I mean, the traditional teaching has been that if the more you share, the less you feel burnout, the more you share your feelings. So could it be that it's a generational gap? You know, we used to communicate with our friends or colleagues on a personal level or perhaps on a telephone, and it's just that the new generation may be more accustomed to using things like Facebook or WhatsApp to communicate with each other.
I think there are usefulness for WhatsApp and Facebook, but it saps up your time a lot more. And I think that you have to balance the positive and negative. I use WhatsApp a lot. I go to, I visit South America, and I've done a lot of visits to developing countries. They can send you so much information about patients, and we communicate like that, which is fine. But to give you an example, I joined this WhatsApp group on my class. You won't believe it. I actually archived it because I figured out that it was overwhelming. It was 400 things coming up every day. I mean, that is impossible to look at and do. So I think you have to find a balance. Yes, Facebook is good. I find it that definitely is a generation gap, but I have younger daughters and they don't go on Facebook anymore, just to let you know, because it's losing its charm, I think. But they find other means, talk to their friends on FaceTime and do those things. But everything has to be in balance and moderation. I think that's the problem, is you get sucked up with all these and it's really impossible to, and that's a lot of time goes into that. So absolutely agree, generation gap. I'm not a Facebook member, but I like WhatsApp. And the reason is there's a lot of positivity in WhatsApp. And even in the US now, we are realizing how people are using this social media for negative things. So all the negativity also affects you. So.
Okay, thank you very much, Dr. Shakila. Do we have any more questions before we close the session? Okay, thank you very much. So we'll officially close the session. Thank you for staying so late.
Thank you, everybody.
Thank you. Bye-bye.
And thank you, Dr. Alina, for running around the whole session. You deserve some rest now.